Good afternoon, good morning, good evening, depending on where you in the world you're listening to this Kapuscinski Development Lecture. My name is Ronan O'Connell and I'm President of the Royal College of Surgeons in Ireland. Founded by Royal Charter of George III in 1784, RCSI was originally established to improve standards in surgery in Ireland, and it continues in this role as one of the 4 surgical royal colleges in Great Britain and Ireland. But RCSI is also a vibrant university of medicine and health sciences with campuses in Ireland, Bahrain, and Malaysia, with over 26,000 alumni in 94 countries. Our mission is to educate, nurture, and discover for the benefit of human health. And we do this through endeavor, innovation, collaboration, research, and service. Today, we are privileged to join with the European Commission Directorate General for Development and Cooperation and the UN Development Programme in acting as host for this Kapuscinski Lecture, the latest in a series of lectures to honor the memory of Polish journalist and writer Ryszard Kapuscinski. Kapuscinski devoted his life to investigative journalism, reporting from war zones, refugee camps, poverty, and deprivation. His views can be summarized in a quotation attributed to him: "We cannot understand our problems if we don't think of them in a global perspective." I cannot think of a more appropriate day to deliver this lecture, as it coincides with the opening of COP26 in Glasgow. I would like to invite Ms. Barbara Nolan, Head of Representation of the European Commission in Ireland, to say some words of introduction, and she will be followed by Jan Szysinski from the UN Development Programme, who will give some background to the Kapuscinski Development Lecture series. So, Barbara.
Thank you very much, Professor O'Connell. I'm delighted to be able to join you today for this important Kapuscinski Development Lecture. I'd like to thank Professor O'Connell and the Royal College of Surgeons in Ireland, and also, of course, the United Nations Development Programme for bringing us together. As Professor O'Connell said, the Kapuscinski Development Lectures aim to stimulate the reflection on strategic topics around international cooperation and development. Since the series began in 2009, more than 100 lectures have been delivered by development policy thinkers and international experts. And while the audience is primarily aimed at, our lectures are aimed at students, we also reach out to include the academic community more widely, government officials, parliamentarians, journalists, and other bodies working in the area in the development field. We want to reach out, in fact, to the whole development family. And the lectures are also live streamed, which, to try and make sure it has the biggest possible impact. The theme of today's lecture, which is Cured into Destitution, Surgery, Poverty, and International Development, I think is very pertinent to the challenges faced by lower income countries across the world. Studies show that surgery can treat about 30% of the global burden of disease. However, it's disappointing that only 6% of surgical interventions occur in low income countries. The number of people without access to essential emergency surgical care is estimated to be around 5 billion, which is a pretty terrifying statistic, I think. So this means, of course, that we need investment, sustainable partnerships, and innovation to ensure universal health coverage and access to safe and affordable surgery for all. In the European Commission, we have a specific Directorate General dealing with international partnerships called DG INTPA, which used to be called DG Development in the past. And this department is responsible for formulating the European Union's international partnership and development policy, with the ultimate goal of reducing poverty, ensuring sustainable development, and promoting democracy, human rights, and the rule of law across the world. Last year, INTPA was responsible for providing assistance of around 7.2 billion euros to some 130 countries on 5 continents. And I think many people will know that the EU and its member states collectively form the world's largest donor, accounting for more than half of global official development assistance. So, you know, we are a big player in this field, and it's important that, you know, we get it right and listen to those involved in the field, in the development field, and make sure our programs are tailored to addressing the right problems in the right way. The Global European Instrument facilitates the European Commission working with countries and regional programs, and will support capacity development, strengthening of health systems in Africa. The aim is to increase equitable and sustainable access to quality health services. Progress in this area is expected to benefit all medical and surgical disciplines. We also have the Horizon Europe program, which is the European Research and Innovation Framework program. And this is investing in new solutions for access to sustainable and high quality healthcare, while trying to unlock the full potential of new tools, technologies, and digital solutions. So we link in also with what we call the Team Europe approach, which was launched by the Commission as a joint response to COVID-19 by all European development actors to support the promotion of European policy priorities and standards. And as part of that programming process, around 150 ideas for Team Europe initiatives have been identified. And these are going to be transformational projects, flagship projects, which will be, the idea is that they will open new doors to producing health technologies in Africa in the long run, which match with African needs. So I just wanted to give you a flavor of some of the things that are sort of, that we are doing in this field. There are different instruments being brought together to make sure that we have a holistic approach to the problems that are arising in healthcare in the lower income countries. So increasing awareness of the complex aspects of global surgery will help us to better coordinate our programs and funding to try and close the significant health gaps that we see across the world when it comes to comparing, you know, how we are dealing with things, for example, in the more developed world, in contrast to the less developed world. So I think that that's enough for me. I'm sure you're all looking forward to hearing Professor Mark Shrime speak on the complex and multi-directional interplay between surgical care, poverty, and inequity. To our audience online, I invite you to join the debate on Twitter by using the hashtag, which is hashtag KAPT in capitals, and then but the capital T is part of the talk. In the rest of the sentences in small letters. I'd like to thank you all very much. I see there are hundreds of people online, which is really, really heartening. And I now pass back the floor to Jan Cieszynski, the Kapuscinski Development Lectures Coordinator in the United Nations Development Programme. Back to you, Jan, and thank you all very much.
Thank you very much, Barbara. I'd like to thank, of course, Mark Shrime, Professor Shrime, for accepting the invitation for this lecture. We tried for some time to do it. It needs to be online, which has its disadvantages, but also a clear advantage that we can be joined with so many students from outside of Ireland. We're really privileged to work with the University of Medicine and Health Sciences in Dublin, which is hosting the event, and of course our strategic partners, the European Commission. In this event and the series of events of the Kapuscinski Development Lectures, in this series, we usually actually focus or tackle the different developmental topics in more general way. So the larger developmental policies, sustainable development, and so on. And it's actually quite rare, at least for now, until now, to focus on a more specific topic like here today, the surgery. And that's why we are so thrilled and excited to do it, actually, because if we want to make a difference in development, we need to be specific about some particular topics, particular needs, and solutions. We are also very happy to organize the lecture on the health topic because it's also so fundamental in the sustainable development goals, as of course specific goals and specific targets that the world committed to achieve in different health aspects. But it's also very important mainstream targets, which really affects all the other targets and goals, developmental goals, including the education, gender balance, and so on. We are also encouraging you, the audience, to ask the questions using the Q&A function. We'll see how many we get in the end, but there's a chance that they will be asked to Mark Shrime after his speech. So thank you very much, and we're getting back to Professor O'Connell.
Yeah, and thank you very much. It gives me great pleasure to introduce Mark Shrime. Mark is the O'Brien Chair of Global Surgery here at the Royal College of Surgeons in Ireland. He's also a lecturer in global health and social medicine at Harvard Medical School. Mark's interests focus on surgery and the delivery of surgery in low and middle income countries, specifically the intersection of health, impoverishment, and inequity. His work aims to determine optimal policies and platforms for surgery delivery that maximize health benefits while simultaneously minimizing the risk of financial catastrophe, which is often faced by patients. He is a co-author of the Lancet Commission report, Global Surgery 2030, which highlighted the deficit in equality of surgical and anesthesia availability. His lecture today, I'm sure, will interest all who have tuned in. Cured into Destitution: Surgery, Poverty, and International Development. Mark.
Thank you, Professor O'Connell. Let me go ahead and share my slides. All right. Yeah, so thank you all for being here. Thank you to the prior three speakers for this really impressive introduction. And thank you to all of you for spending an hour in your afternoon, your morning, your evening with us here at the Kapuscinski Lecture. What I want to talk about today, as has been foreshadowed, is the intersection between surgery, impoverishment, and development. Now, if you're anything like me, the fact that there is somebody coming up and telling you that there is an arrow that connects impoverishment to surgery is kind of boring, because we know that. We know that if you are poor, it is hard for you to access high-cost medical services like surgery. But that arrow connecting impoverishment to surgery is not unidirectional. There is another arrow going the opposite direction, implying, as the title of my talk implies, that some people who access surgery can be pushed into destitution by that access. And we're going to address this about midway through this talk. As has been kind of alluded to already, if you've been to a Kapuscinski lecture before, this is not the typical Kapuscinski lecture, in that usually the lecturers don't use slides, and I'm obviously using slides, and they usually speak for about 45 to 60 minutes. I'm only going to speak for about 20 minutes because we really want to leave time at the end of this for questions. So after my talk, Professor McNamara and myself will have a bit of a fireside chat. I have my tea in front of me, and then we'll open for the third of this hour. We'll open the floor to you all to ask your questions. As Jan has already said, there's a Q&A button at the bottom of your Zoom screen, so please feel free to use that to put in your questions. Don't feel like you have to wait till the end to put in your questions. If you think of a question as I'm speaking, just type it into the Q&A box. Okay, so I want to start. Oops, that didn't work. I want to start with a quote from Kapuscinski himself. Now, in this quote, he is talking about food, but as you'll see, the ethos behind this quote applies to surgery as well. He writes, "People are not hungry because there is no food in the world. There is plenty of it. But between those who want to eat and the bursting warehouses stands a tall obstacle indeed." So let's talk about this tall obstacle. And I want to talk about this tall obstacle through the lens of a patient's story. Because those of us who work in global health, in development, in global surgery, we love to talk about things like GDP and cost effectiveness and throw some big numbers around, and we'll be doing that later on this talk. But most of us got into this field because what we really want to do is make the lives of patients better. So let's address this tall obstacle that Kapuscinski writes about through the eyes of a patient. So I'm going to introduce you to a patient of a colleague of mine. I did not operate on this patient. And if you're at RCSI and you've heard me speak before, you've met this patient before. His name is Sambani. He's a rice farmer from the southern part of Madagascar. And he has had a tumor growing up the left side of his face for 30 years. Now, there are a couple of different ways, different common ways to look at a picture like this. I can't see any of you guys, but I'm told that the majority of you are medical students. And so some of you will therefore be interested in surgery. And as a surgeon, I look at this picture in a particular way. I see this tumor and I start to think of the sort of surgical approach that we take to getting this tumor out. You'll remember from your anatomy classes that the facial nerve exits the base of the skull right behind the ear, branches into 5 different branches as it goes towards the midline of the face. And you can kind of see on this picture that the 4th branch of Sambani's facial nerve, the one that moves his lower lip, is paralyzed, has been paralyzed by the tumor. But the other 4 branches are working just fine. So the question is, how do we take this tumor out while maintaining the integrity of his facial nerve? Or what is the relationship between this tumor and the great vessels in the neck? That's one way to look at this picture. The other common way to look at this picture is a way that my non-medical colleagues turn to way more frequently than us medics, and that is to find the patient's humanity. It's to say, listen, Sambani, for 30 years, nobody has seen you. They've seen your tumor. Nobody looks you in the eye. They look you in the tumor. I choose to see you. And I think these are 2 really important ways to look at a picture like Sambani's. In fact, you could give an hour-long talk on each of these ways to look at a picture like Sambani's. But what I want to encourage us to do for our hour together is to look at this picture in a 3rd way. Not to see the tumor as a surgical problem to solve, but also not to disregard the tumor altogether in search of the patient's humanity, but to see the tumor for what it is, a symptom of a deeper, underlying, systematic disease that those of us who work in global health, I believe, are duty-bound to diagnose and to treat, because this deeper underlying systematic disease prevents Sambani's development, and as we'll see in a bit, can prevent the development of countries as a whole. And I'm going to fill you in on Sambani's story in just a couple of slides, but a little bit of background first. It's been very difficult for a long time for patients like Sambani to access surgical care. So difficult, in fact, that in 2008, Paul Farmer and Jim Kim wrote that surgery is the neglected stepchild of global health. And that's really been true. Surgery really wasn't part of the global health conversation for a good reason. In the ether for a long time was the idea that there's not a lot of surgical disease burden, that most people have decent enough access to surgery. And as a result, investing into fixing surgical systems is just too expensive for those few who don't have decent access to surgery. And this has been kind of in the ether for a long time, not for no reason either. There's some research to back these statements up. Back in 2006, Haile Debas published an estimate of the global burden of surgical disease, estimating that 11% of the world's disease burden is surgical. Now, to give you a little bit of context, HIV, TB, and malaria combined are about 10% of the global burden of disease. Now, I respect DeBoss to no end. He's very much sort of the grandfather of the global surgery movement. But what this paper implied is that 89% of the burden of disease doesn't require interaction with the surgical system. In 2010, Funk and his colleagues looked at the global distribution of operating rooms and found that 2 billion people around the world don't have access to an operating room. So if 90% of the world's disease burden doesn't require surgery, and 5 billion people around the world have decent access to an operating room, then it is absolutely correct for surgery to be the neglected stepchild of global health. It's absolutely correct for the world to invest its time, its money, its energy into things that give it more bang for its buck. Things like bed nets for malaria, things like vaccinations. One of the questions that I want to ask, and Ms. Nolan has foreshadowed some of this, is are these things actually true? And let's start with this question of, do most people around the world have access to care? If you think about how I described Funk's paper, they looked at the global distribution of operating rooms, which is just one dimension of access. It's just, is the operating room available to you? It says nothing about whether that surgery that you get there is safe, whether you could afford it, or whether you could get to it in time. And the question is, using a more holistic definition of access, how many people do or don't have access to surgery? And here I want to turn back to Sambani's story. I want to tell you the story behind this tumor, because as we start talking about the story, you'll start to see the outlines of this deeper underlying systematic disease. You'll start to see barriers across each of these dimensions of access. Because in his 30 years, it's not like Sambani didn't know there was a tumor growing on his face. It blocked the eyesight from his left eye. He knew there was a tumor there. And in fact, he'd been to 10 different hospitals over those 30 years, only 3 of which had surgeons in them. None of those surgeons would offer him a procedure. He finally had his surgery with a charity that I work with that was working on the east coast of Madagascar at the time. He's a rice farmer from the south. So to make that trip from the south to the east meant that he had to be carried on somebody's back for 2 days just to get to the nearest road. And then it was a 6-hour trip up the road to get to the hospital. So already in Sambani's story, you're starting to hear the outlines of this deeper underlying systematic disease. You're starting to hear barriers around distance, transportation, timeliness, a lack of providers, a lack of procedures offered by providers. There is a barrier, there's a part of Sambani's story that interests me in my research particularly, and that is this. That charity that did Sambani's surgery offers the surgery for free. Surgery, the medications, the postoperative care, all the things that you would need at no cost to the patients. And yet, to make that 2.5-day trip from the south to the east of Madagascar, this rice farmer had to sell his rice farm. So he was cured into destitution. He faced a catastrophic financial event in search of his free surgical care. And Sambani is not alone in facing these barriers. Around the world, there's a real reluctance to seek surgical care. Now, sometimes that's simply because of a lack of knowledge that surgery can treat what ails you. This is often seen in cataract surgery, but often it's because of a fear of that safety and that affordability. And if you decide to get care, care is often too far away. This is slightly old data, but this is the WHO's estimates of the median distance. The horizontal line is the median between you and your nearest health post, to say nothing of whether that health post can actually perform surgery at all. In high-income countries, we are on the median about 5 kilometers away from our nearest health post. Low and middle-income countries, 30 to 35 kilometers. But there's a little bit more in this graph than just that. Those rectangles are the interquartile range, which implies that 25% of the population in low and middle income countries lives more than 65 kilometers away from their nearest health post. I grew up in Texas. 65 kilometers is what you did to go to school in the morning. But 65 kilometers in rural Madagascar, where the roads are really terrible or don't exist at all, can take you days. Let's say that you have a tumor growing off the side of your face and you want to get it taken care of, so you're willing to make a days-long trip to get to a health post. If you get there, surgical care may not be available, and it may not be safe. This is the WHO's estimates of the proportion of hospitals that don't have electricity, 1/3, running water, 1/5, oxygen, 1/4. Fully 50% of the world's hospitals don't have a postoperative care area, which dovetails with one of my favorite papers ever published almost a decade ago now by Renee Shaw, Margaret Crook, and others. In this paper, they looked at something like 700 hospitals in half a dozen sub-Saharan African countries. And they asked, forget staffing, forget affordability, let's just look at infrastructure. How many of these hospitals have the infrastructure necessary to meet the minimum standards the WHO has deemed essential for the provision of emergency and surgical care? Hundreds of hospitals, half a dozen countries. The answer was 0, not a single hospital. But let's say you've got that tumor, you make that days-long trip, you find the one needle in a haystack hospital that Renee and Margaret missed. You get there for your surgery, it may not have surgical staff in it. Every country on this map that is not blue, every country that's red, orange, yellow, purple, brown, is a country that has to scale up its surgical workforce just to meet the bare minimum surgical requirements of its population. We're talking C-sections, appendectomies. We're not talking complex tumor removal like Zambales. And Madagascar, where he's from, definitely not blue on this map. So the first point that I want to make here is that when you start taking the entirety of access into account, when you take availability, safety, timeliness, I haven't even gotten to affordability yet. When you take all of these things into account, it's not 2 billion people around the world that don't have access to surgery and 5 billion who do. As Ms. Nolan said, it is exactly the opposite. 5 billion people around the world don't have access to safe, affordable, and timely surgical and anesthesia care. Which brings me to the next point that I want to make. Surgical volume around the world, on average, is critically low, but that's on average. This right here is the bursting warehouses that Kapuscinski was talking about. Every year, 313 million operations are done around the world, only 6% of which happen in low-income countries. To meet this unmet need, to fill this gap, the world would need to provide an additional 143 million more procedures per year. Now that averages out to about 5,000 procedures per year for every 100,000 people in the population of a country. 5,000 procedures per year per 100,000 people in the country. Madagascar is at 191. To meet that 5,000 number, countries need to have between 20 and 40 surgeons, anesthesiologists, and obstetricians for every 100,000 people in the population. The US is at 63, Madagascar is at 0.78. And to meet this need, to fill this particular warehouse, the world would need to train anywhere between 1.3 and 2.3 million new providers. That's the second point that I want to make. The third point gets back to what I missed in point number 1, which is affordability. As we heard from Sambani's story, people, because surgery is expensive, people can be pushed into poverty by accessing the surgery. And again, Sambani is not unique. Every year, 81 million people, 16 times the population of the Republic of Ireland, 81 million people are pushed into poverty from the costs of surgery. But if you're paying attention to Sambani's story, you should tell me, wait, he wasn't pushed into poverty by the cost of surgery, because that surgery was free. He was pushed into the poverty by the costs, the ancillary costs, transportation, food, lodging, and again, Sambani is not alone. Of that 81 million, only 40%, 33 million, is attributable to the direct medical costs of care. 48 million cases of impoverishment come from those ancillary costs of getting to care. But what this means is that 1 in every 4 people who get surgery every year are pushed into poverty by the cost of surgery. And that's just people getting surgery. And my first 2 points were about how people who need surgery aren't able to get it. So we asked that question as well. how many people around the world, if they needed surgery today, if they needed a C-section, if they got hit by a car, how many of them would be pushed into poverty by the costs they would have to pay to get that taken care of? And that number is 1/2. 1/2 of the world's population, just like somebody, would be pushed into poverty by getting access to surgical care. And that half lives in the places that you think they would live: Sub-Saharan Africa, South and Southeast Asia. So the first 3 key points here are painting a bit of a dire picture. They're kind of where we are right now. But the next points that I want to make are, the first one is that fixing this problem, investing in the scale-up of surgical systems, promotes economic growth and is cost-effective. Let's start with promoting economic growth. The estimate for how much it would cost to bring surgical systems around the world up to where they can cover the basic surgical needs of their populations, again, C-sections and appendectomies, over 15 years, that would cost $350 billion. $350 billion is 10 times the annual GDP of the country of Uganda. It is a lot of money, but it pales in comparison to the $12.3 trillion left on the table in GDP losses if we do nothing. So there's a very strong macroeconomic argument for investing in surgical systems. But then let's get to this other thing that we said at the very beginning. Is that investment too expensive? Too expensive is a value judgment. Investing in surgical systems is expensive. There is no question. But to say that it's too expensive is to say that we aren't getting enough bang for our buck for that investment. And to address that, let me show you the results of a systematic review by Chow et al., looking at how much it would cost to buy 1 year of healthy life for a whole bunch of global health interventions. In blue at the bottom are global health interventions that the world has signed on to. Things like bed nets, things like antiretroviral therapy for HIV, which would cost between $450 and $650 US to buy 1 year of healthy life. And we've said $450 to buy a year of healthy life, that's a really good investment. We'll opt for that. We will pay for that. We'll buy that. Well, if that's true, and if we're consistent with our valuations, look at how much it costs to buy 1 year of healthy life on the median for surgical interventions in red above. They are all less than $450 US. So there is a macroeconomic case for investing in surgical systems. There is a cost effectiveness case for investing in surgical systems. And fundamentally, surgical systems, surgery is an essential part of the provision of universal health coverage. Now, I can show you this in 2 ways. I'm going to show you numbers in just a second, but let's do a second thought experiment here. Let's say that I came to you and I said, you know what, I am tired of living in Ireland, tired of living in the US, I'm going to start my own country. And I'm working right now on the design of my country, and I'm working on the design of my health system. And I think I can keep my population healthy enough without really investing in a surgical system. Would you sign up to be a citizen of my country? And I'd wager that you wouldn't. And that's because we don't really believe that 90% of the world's disease burden doesn't require interaction with a surgical system. And in fact, we redid this analysis, and it turns out that it's not 11% of the world's disease burden that requires surgery. It is, as Ms. Nolan said, 30%. And that 30% distributes itself across every disease category. In the SDGs, we as a global community have committed to lowering maternal mortality down to less than 70 maternal deaths for every 100,000 live births. We aren't going to do that without surgery if 35% of maternal admissions to the hospital require surgery. We won't make a dent in cancer mortality without surgery if 62% of cancer admissions to the hospital require surgery. Which brings me back to close to Sambani's story. When you first see a picture like Sambani, let me put up the SDGs here. When you first see a picture like Sambani, we're all tempted to view Sambani as an epitome, as a paragon of SDG 3. We're tempted to view Sambani through the lens of medical care, of health and well-being. But if we do so, we ignore the fact that both Sambani's condition and his surgery can impact his poverty, can impact his hunger, can impact his is opportunity for decent work, the opportunity for the country for economic development. So we talked about huge inequities in the provision of surgery. What I haven't talked about for time is that in pediatric surgical conditions, the condition can interfere with kids going to school. There's a massive gender inequity in access to surgery. And fixing this problem is going to require innovation around infrastructure and is going to require partnership to achieve these goals. So surgery, while it looks like it only impacts on SDG number 3, can have an impact on 9 different SDGs. We in the medical community are really good at surgery. We're really good at tackling the puzzle of this tumor, really good at taking somebody from here to here. But if we truly want to make things better for people like Sambani, we have to listen to, diagnose, treat that deeper underlying systematic disease. We have to create equity in the bursting warehouses of surgery. Thank you very much.
Mark, thank you as always for a very thoughtful and very thought-provoking presentation. And every time I've seen Salmini, it resonates. It really does illustrate and resonate with me. I'm pleased to introduce my friend and colleague, Professor Deborah Mcnamara. She's a consultant general and colorectal surgeon here in Dublin. She trained in Ireland and also at the Hôpital Saint-Antoine in Paris. And she's now co-lead of the Irish National Clinical Programme for Surgery and is a council member at RCSI. And Debbie, I'm looking forward to your interview with Mark.
Thank you, Professor O'Connell. Professor Shrime, what an amazing talk, and something that I just think will be hugely inspirational to all the medical students and doctors in training who've joined us today from across the world. So I guess in starting, I hope you don't mind if I start with a personal question. Can you share with us what inspired you to work in the area of global surgery, and I guess how that journey led you to RCSI's University of Medicine and Health Sciences?
Yeah, thanks, Debbie. And thank you, Professor O'Connell. I also neglected, to thank the European Commission for funding all this. So let me just say that now before we get to the Q&A session. Yeah, it was a very convoluted path, and I could talk about this for an hour, so I'll try not to. But the short answer is I kind of went into medicine not wanting to go into medicine at all. Went into medicine because that was what my parents wanted. And for a long time, didn't really enjoy my training. Ended up sort of finishing my medical school in the US, finishing my residency in otolaryngology. And then in 2008, after doing a fellowship in Canada, ended up taking a year off altogether. Spent 6 months of the year traveling and being a consumer, and then spent 6 months of the year working with that charity that I mentioned, with that NGO, which is a charity that operates hospital ships. Worked with them for 6 months in Liberia. And I'll tell you, it was one of these sort of road to Damascus moments. I was on the ship, I walked down into the hospital wards. I'd done a fellowship in head and neck cancer, and I wasn't really sure what I was doing with myself. Walked at the hospital wards, and there's 12 different Sambanis right there with different tumors at different stages of recovery. And I was like, oh my God, this is what I've been training for 15 years to do. So I went back, I started on the sort of traditional path of medicine, finished my fellowship, my second fellowship, worked for 2 years as an academic head and neck surgeon in Boston, and realized also that that was not what I wanted to do. That really where I felt like my calling was to work with patients in developing countries, but also work on the systems that we've just talked about here that keep patients having tumors like that. So much to the chagrin of my work partner there, the guy that hired me, I quit and went back to school, got a PhD in health policy, and have kind of been working in global surgery since. Worked for 5 years at Harvard. And then when RCSI announced that they were starting an institute to specifically focus on this stuff, that the draw was too strong. So now I'm here.
Okay, well, thank you. Interesting how you just happened upon it and found that it was right for you. And I think that happens to so many people in their career, doesn't it? I suppose when we were listening to your lecture, I was thinking, you know, we talk a lot about global surgery, but mostly the examples that we use, and they're mostly about very, very poor countries, sub-Saharan Africa in particular. So is global surgery just about surgery in poor countries, or is there more to it than that?
I love that question. So no, it is unfortunate that the example that I gave here is from a poor country in sub-Saharan Africa. And there is, you know, we could talk forever about there is some global health struggles with its own kind of neocolonialism problem. Global surgery, no more or less than global health in general. Really, as Paul Farmer says, speaking of Boston, he says, look, Boston is on the globe too. Ireland is on the globe too. What we're really concerned about here is inequities in access to surgery, wherever those inequities occur, whether they occur in an unhoused population, whether they occur in the Ozarks in the US. We're concerned about that lack of equity to surgical access. It does happen to be that the biggest burden of disease currently is falling on sub-Saharan Africa and South and Southeast Asia, but we focus on those areas because the burden of disease is there, and not necessarily because global surgery is some code for surgery in Africa.
Okay. And I mean, one thing that came to me during your talk was, you know, I know that we're not doing enough surgery in lots of places in the world, and you sort of wonder, is it possible that we might be doing too much surgery in some places? And so that whole issue of inequity and appropriate use of surgical resources comes into it, doesn't it? And I suppose thinking about those kind of macroeconomic effects of having a surgical system that's well functioning, I was really struck that the cost effectiveness of surgery in terms of avoiding disability seems indisputable, really, and yet at the same time individual people are facing this financial catastrophe for undergoing surgery, and that really seems like a contradiction to me. Can you help us to understand that a little bit better?
Yeah, I think there's a lot in that question. So there is a difference, and I'll say this first to start with. There's a difference between cost effectiveness and affordability. They're two different things, not just on the patient level, but even for systems. You can tell a system, you can tell whatever, Madagascar, that investing in your surgical system is cost effective. But if it still costs, $350 billion, that's $350 billion that just may not exist, or maybe in the bursting warehouses in high-income countries instead of where it should be in Madagascar. So cost effectiveness is a system-wide analysis, does not necessarily look at the affordability for patients, which is why we also talk about the affordability for patients. And you're right. And, obviously I spent a fair bit of time talking about the fact that with the systems the way they are right now, patients are prevented from surgery because they are afraid of what it's going to do to their livelihoods. And those that do get surgery are 1 in 4 times driven into a poor financial state. Now, I'm going to see if I can share my slides here again, because I took something out of the talk that might address this. All right, so I'm going to show you some unpublished data here. So don't screenshot what I'm going to show you or anything like that. These data haven't been published yet. But we did a study that in patients in Guinea, patients with maxillofacial conditions like Sambanese. We did a study looking at their outcomes across all sorts of domains, their health outcomes, the outcomes in terms of equity, outcomes in terms of cost effectiveness, but we also looked at outcomes in terms of participation in the community and participation in the economic life of their society. And let me show you the results here. So we surveyed patients here at 0 months, at 3 months after surgery. So preoperatively, 3 months after surgery, and then a year later after their surgery, looking at their average household income. And there are 2 groups of patients here. There's patients getting surgery at local hospitals and patients getting surgery with this charity that I've been talking about. But what you see for both sets of patients is that, sure, yes, there is an initial hit in terms of finances, but their incomes for both sets of patients increase after they get surgery. So yes, there's an initial hit. Yes, that hit is problematic. But there is also an argument to be made here that improving surgical systems actually can give people the opportunity to be economically productive members of society.
Well, that's amazing to see, and I suppose something that really gives us hope, because it's the sort of problem that just seems almost overwhelming in scale. I mean, the numbers you were talking about, they're really big numbers, and I suppose the question is, where do we start with this sort of ginormous problem, and how can we get people who really want to support this work? How can they help?
Yeah, great question. One of the difficulties with surgery, and also one of the things that makes it such an interesting space to work in, is that surgery is annoyingly horizontal. It resists vertical interventions. I'm going to make an analogy here. Treating HIV is not easy. Treating HIV is very difficult. But one of the easy things about treating HIV is that you can create the medicine somewhere. You can manufacture it somewhere, and then all you have to do is bring the pills to the patient. With surgery, you've got to bring the entire means of production close to the patient. Otherwise, you've got people like Samani traveling 2.5 days to get their surgery. So the entire means of production means there is no sort of quick shot solution. There is no vaccination that we can give. There is no bed net. It has to be a very horizontal scale up of the infrastructure itself, the personnel, and it's not just the surgeons and the anesthetists, it's nursing, it's biomed tech, it's sterilization, it's all these other parts of a surgical system. As you well know, it takes a village to do one operation. So what I'd say, people who want to get involved, there is almost no way that you can not get involved if you're interested in whether it's nursing or it's surgery or it's sterilization or it's the building of infrastructure. There's work to be done for all of these things.
Okay, well, that's a really good place, I think, a really good place for us to finish our conversation. I can see that there are lots of questions coming into the question and answer section. Thank you so much, Mark. I've really enjoyed chatting it with you today, and I'm going to hand back to Professor O'Connell now. Thank you.
Thank you, Debbie.
Thank you, Debbie, and thank you, Mark. Fascinating discussion. Can I now invite Dr. Debbie Stainstreet, who's a senior lecturer and interim head of our Department of Public Health and Epidemiology at RCSI. Debbie is a nurse, and she went on to do a Master's in Public Health and a PhD in Liverpool, and we're fortunate to have her working with us in RCSI. She's worked extensively in the area of inequalities, and much of her work has focused on air pollution, and she's currently PI of the Smokeless Village project in Malawi. She's also co-lead of Teen Path, an Ireland-based study looking at inequalities in health amongst young people in Ireland. So Debbie, it's good to see you, and you will now lead the question and answer session with Mark. Thank you.
Thank you, Professor O'Connell. And thank you very much, Professor Shrime, as well. That was an absolutely fascinating, and I have to say, quite a moving presentation as well. I think for me, listening, as a public health person, just the importance of inequalities, it's never been more important given our current situation with the global issues we're dealing with. And it's just so important to see those issues highlighted in the area of surgery. And and the scale of the issue. So thank you very much for that. We've had a number of questions come in. I know we're not going to have time for all of them, but if I can just pick up, Mark, on that question that you just answered about becoming involved. One of the first questions we have here from Lorin, who's an RCSI student, is how can I be part of this movement? I wonder whether you could just break that down a little bit more and provide some kind of guidance as to what medical students might do perhaps during their training and what options they might want to think about post-qualification in order to perhaps go down this route.
That's a great question. One of the things that I like to say to answer this question that probably frustrates the people that are asking it is that the most important thing that you can do as a medical student or as a registrar or resident, if you're interested in global surgery, is be the best dang medical student, resident, or registrar that you can be where you are. Because for multiple reasons. One of the, if you want to be clinically involved in global health and global surgery after you're done with your training, you're going to face conditions, you're going to face cases that you will have never seen in your training. And you need to be comfortable enough with your surgical skills or your anesthetic skills that you are willing to tackle these cases. So it's amazing. It's, as to say, it's all well and good. It's more than all well and good. It's amazing that there's such an interest in being involved in global health and global surgery. I would say foster that interest, but don't foster it at the expense of putting your entire effort into being a good medical student, being a good resident, getting the training that you need so that you're able to do this. With that said, there are a bunch of student organizations that are involved in global surgery. Incision is one of them. It's a global, it's an international collection of medical students interested in the global surgery space. There are opportunities, if you're an RCSI student, there are opportunities within RCSI as well. So there's, since 2015, since the Lancet Commission on Global Surgery, there's been an ever increasing number of master's degrees, post-grad degrees, even clinical fellowships in global surgery. So I'd seek them out. But again, I'd seek them out with paying most attention to making sure you've got the anatomy, the physiology, and the surgical technique all down as well.
Okay, thank you. Thank you. So some really practical examples there, Mark, for students to follow. I'm just going to mention the dreadful C word because it's been mentioned by a number of students. But it is actually quite relevant in this context. And it's Maria in the Philippines who is making the point that the medical systems there for the poor have actually been quite overwhelmed during the pandemic. And she's asking what we might be able to do about this. And I think probably regardless of where we're based, we've all had a similar experience, maybe not on the same scale, with our own health systems. So how might that feed into some of these issues now around surgical access?
Great question, Maria. So a couple of thoughts here. One is that I think very appropriately, one of the first things that happened for every spike in every country around the world was that elective surgery was put on hold. And I think it should have happened. Like, I honestly think that the infrastructure, the resources of a hospital in the middle of a pandemic should be devoted to the pandemic. That's very true. But what that does then is it creates a massive backlog of surgical cases, delaying presentation of these surgical cases. So smaller tumors end up bigger, fractures end up not healing in malunion. So yes, perfectly appropriate to put elective surgeries on hold, but now we've got this massive backlog and delayed presentation to deal with. And that also, as with everything in this pandemic, fell on poorer patients within every country more heavily than on richer patients. So as COVID has done with everything else, it has highlighted and widened the inequities that we're seeing in surgical access as well. I think that means that we've got an even bigger task ahead of us now as we're hopefully coming out of the pandemic. We now have to, really push on the gas to scale up surgical systems to address this backlog.
Yes, yes. And maybe as well, as Professor O'Connell mentioned earlier, given that we're now looking at COP26, which has just started, can I also ask you, in your opinion, what do you think is the intersect between climate change, poverty, and access to surgical care?
I love this question. It's something that the global surgery community is only just starting to focus on. The fact is, because surgery there's no two ways about it, is a bit of it's an expensive endeavor. And it's an expensive endeavor on some level because we go through a lot of stuff. We go through a lot of materials, sutures, endotracheal tubes, gloves, et cetera, you name it. We go through a lot of stuff in any operation. I'm only just starting to hear of units around the world starting to look at the sustainability of hospitals themselves. And here, I really, really think that we in the global north can learn from hospitals in the Global South who have already had to deal with and figure out how to operate in resource-constrained settings and have innovated around where does the power come from, where does the oxygen come from, how is the food created, delivered in my hospital. It's, we shouldn't be reinventing the wheel. The wheel has been invented. I think we can learn a lot from what's been invented in some of our partner countries.
That's really interesting, and a whole new avenue for research and practice for us to think about in the future. Now, I'm going to move on to a couple of questions from medical doctors. These two questions are slightly overlapping. So Dr. Brendan O'Shea from the ICGP and also Sarah Bernhardt, who is working for the EU delegation to Libya, they're raising the issue of primary care. And if I can just say something a little bit about Sarah's situation, where Sarah is based working with a Libyan audience, then she's making the point that your presentation would receive a standing ovation. But in fact, they have huge difficulties in actually getting enough resources into the primary care health systems, which are obviously supporting the surgical systems as well. It's a two-way process. So from a practical point of view, and in terms of thinking about systems, how do we do this together in parallel, in a synchronized way, that we make sure that primary care is also in a stronger position to be supporting surgical care in low-income countries in particular?
Yeah, I have two thoughts on this. First, I think there is an unfortunate divide in the way that we speak about primary care, an unfortunate divide that just kind of implies that surgery is something other than primary care, because we have the sense that surgery is what somebody just had, or maybe surgery is rhinoplasties or something else. So surgery is this kind of icing on the cake that we can deal with once we've figured out primary care. The fact of the matter is, surgery should be part of primary care. Surgery is part of primary care. And surgery is the first thing that you need if you get hit by a car. Surgery is the first thing that you need if you have an obstructed labor. So surgery really should be the first place that some of the conditions go. So this artificial dichotomy between primary care as the GP who treats your diabetes or your hypertension, and then the surgeon over here doing the things that the surgeon does behind a black box, I think is an artificial divide. The other thing that I'd say is that, as I said before, surgery is sort of annoyingly horizontal because you've got to deal with the electricity and the suction and the water and the staffing and all of that to deliver an operation. But the fact of the matter is, if you're focusing on the electricity and the water and the suction and sterilization to deliver an operation, well, you've just fixed the electricity, the water, the sterilization, and the sanitation in the hospital. So there is this idea that focusing on surgery will have knock-on effects for the hospital in general that will bring the entire hospital delivery up.
So the answer, and I guess, again, this is not specific to thinking about low-income country situations. It's also about the system overall and how those systems are working together, which is so incredibly important. I'm going to pick on a question here. I don't know whether we have our Emeritus Professor Rory Brewer on the call, but I have a couple of questions here that he would certainly be very pleased with. One is from Ali Herbert, who is Samaritan's Purse, and also from Thomas Weiser. I don't know whether you're a student, Thomas, from the question, but Ali and Thomas are asking about the training of surgeons. And Ali is saying those people who train abroad, often they stay away from home, and how do we encourage them back to their home countries? And Thomas is just saying, what are some of the funding approaches that might address this inequity in terms of brain drain and ability to retain surgeons?
Thank you. First of all, it's good to see Ali's name on here. I've known Ali for probably like 15 years now. And Tom, just to give him a bit of a shout out, Tom is has been behind Lifebox, which has brought pulse oximetry to, I don't even know, Tom can tell us, thousands, hundreds of thousands of hospitals around the world, and are now working on other infrastructure developments. This idea of brain drain is pretty huge. We published a paper a couple of years ago now that estimated that the cost of brain drain was something like $16 billion to the source countries, the countries that train the providers, and then the providers leave. So when the providers leave, what they're leaving with is all the training that they just had, and therefore the ability to treat the conditions and, again, bring people into economic viability within the country. There are some programs that do work in that. RCSI for 15 years has partnered with COSEXA, the College of Surgeons of East Central and Southern Africa, in training surgeons within the COSEXA region. And the folks that have been working on the COSEXA program might correct my actual number here, but recently published data showed that something like 90% of the surgeons that were trained in COSEXA, certified, licensed, fellowshipped in COSEXA, stayed in the COSEXA region. There's another program called the Pan-African Academy of Christian Surgeons that has published similar results, that training surgeons within a country who are committed to staying in the country actually works, actually keeps the surgeons in country. So yes, brain drain is a massive problem, but by focusing on it, you actually can reverse some of that effect. As for Tom's question about funding, gosh, I wish I had the key to that. I think we all wish we had the key to that. Part of the problem with surgery being viewed as the neglected stepchild is that the funding structures don't follow. So as I said in my talk, about 10% of the world's disease burden is HIV, TB, and malaria. That takes the lion's share of global health funding. And even if it was just 10% of the global burden of disease that was surgical, we still aren't sort of equal to HIV, TB, and malaria funding. This is an advocacy question. This is an issue where we just sort of have to keep pushing at, hey, this is a real problem. This is a problem that affects you, and almost everybody will require surgery at some point in their lives. It's starting to change. I know USAID has started to include surgical terminology in their mandate. So things are moving, but how we finance this right now has relied on sort of smaller research grants, or has relied on philanthropic donations and implementers, organizations like Operation Smile, like Mercy Ships, who are interested in kind of leading the way here and putting their money where their mouth is and trying to fix some of these problems in the countries in which they work.
Yes, it's a big question and a big issue. I'm just aware now, Mark, that the time is running on here, and I don't know how much longer we're going to get. So I'm going to move on to this question kind of at the other end of the spectrum. I think this may be our last question now, from someone who is actually a surgeon in Africa. And Yana Malik is a plastics resident in Kenya, and he's also an MPH student. And Yanan is asking, Yanan is saying he's very keen on improving the data in their country to be able to influence policy making, and would like to get access to some kind of mentorship for this kind of project. Is there any sort of opportunity for that at all?
That's a great question. And I think this push to want to improve data is so well placed. One of the things in all health systems that kind of lags behind the provision of care is training up the research and data and public health base for all of this. So really happy to hear that this is of interest. Again, lagging behind, there aren't a ton of programs that are offering things like master's degrees or things like mentorship in global surgery data collection. They are increasing, but there aren't a lot. What I will say, though, is to keep your eye out. A lot of us in the global surgery world are in the middle of trying to put together, and I'm expecting this won't be out until 2023, is almost a how-to guide. The Lancet Commission, which I didn't cover in my talk, put out 6 metrics by which you can measure the health of a surgical system. Things like timeliness, things like catastrophic expense, things like the number of surgeons. And what we're trying to put together is really a how-to guide of, if you want to measure these 6 indicators, here are the surveys that you could use, here are the ways to calculate it, here's how you would actually do it stem to stern. So we're not there yet, but we're working to try to make that more accessible as well.
So a tool then really, Mark, that other countries can use. And do you have a kind of time scale on that at all?
I don't. We're hoping that we'll have the thing written by early to mid 2022, and then however long it takes to get that into the journals and published. But really a tool that would be off the shelf. You could really just sort of grab and say, I want to do this in my hospital. Here's how I do it.
Okay, thank you. Now, I think I've been given permission for one more question. Professor O'Connell is nodding, yes, okay. So we'll go with that. We have a question here from Gillian Henker, SISU Global Health. And Gillian's asking about which organisations would you say have actually been perhaps the most effective in bringing surgery to parts of Africa where there is unmet need, and perhaps you can expand on why you're choosing those particular organisations as being effective.
I mean, I think I would be hard pressed to pick an organization necessarily to say, these are the best. What I would say, only because I'm gonna miss somebody and then I'm gonna make somebody mad. But what I would say instead is, if you're interested in working with organizations, don't look at just, can I fly into a place and work for a couple of weeks and then fly back out? Look at how the organization is or isn't investing in the places in which it's working, how it's investing in the surgeons within the countries, how it's investing in scaling up the surgical system within the countries, how deep and how long-standing is that intervention, is that organization? Because a lot of us have this desire to help. We've got an altruistic streak. And it's really easy to say, cool, well, I'm gonna fly to Madagascar and take out tumors like Salmonese, which is good, but really is only the tip of the iceberg. And what I would say, really sort of look into organizations that invest in health system strengthening, that invest in following up on their data and seeing what actually happens, that invest in these sorts of things that aren't just a way to fly in and fly back out.
Yes, thank you. So be strategic about your choices, and I think that's very, very useful advice for medical students. So just to say, Mark, thank you so much for sharing your incredible knowledge, and you've shown the breadth of your knowledge in the way that you've responded to these really quite diverse questions. And I have absolutely no doubt that there are many medical students on the call who have been inspired by what you said, and that's really exciting, because they're going to be the next generation to be out there making a difference at a time where we really need them to be doing that. So thank you very much, and I will hand over back to Professor O'Connell.
Thank you, Debbie, and thank you, Mark. I think Debbie has summarized it very well. You've been an inspiration in your talk and in your response to all of the questions. I have to say, reflecting on it, that the experience of traveling overseas, be it to a wealthy country or an impoverished country, is always formative. And you see other systems, you see things that are better than what you can do, but you often see things that are not as good as what we do. And certainly for the medical students here in Ireland, where we have our inequalities in health, we're still very, very fortunate in what we have here. And it behoves you to look outside the country and do what Mark did. Look to go and get an experience as a student during your summer, or even better, to take 6 months or a year once you've got something to give. It's not just about taking, you have to have something to give. And I think that's what lit your fire, Mark, when you went and you found you had something to give and there was great need. I think we have honored the memory of Richard Kapuscinski in his endeavor to bring to the general public the understanding of problems in those areas that are disadvantaged. You join, Mark, a list of illustrious previous Kapuscinski lectures that go from Nobel laureates to politicians to social sciences, even to royalty. So we're very grateful to you. RCSI is grateful to the EU Commission and to the UN Development Programme, and to Jan Szaszynski and Barbara Nolan for their support today. And it would be remiss of me not to acknowledge our own Deirdre Mcnamara, who has been absolutely pivotal in organising everything from our end. To the more than 400 people who joined us today, I think this has been an interesting and formative lecture. I hope you'll remember it, and I hope that some of you will act upon it. And with that, I send greetings to you all from Dublin, and hope that as COVID, we hope declines and we can travel again, that we'll be able to experience some of the things that Mark has talked about. So thank you all, and good afternoon.